Dr. Moulin.
Very good. Thank you very much. It's easier than buprenorphine, so I figured you're.
That one took me a while.
I knew you were going to do well.
Thank you.
I don't know if the slides are up, but I'm Dr. Aimee Moulin. I'm an emergency physician and addiction medicine physician. I also work for California Bridge, which is an effort to expand access to addiction treatment. And next slide. One of our key tenets, and I think this should be the piece that drives us, is that all people deserve rapid access to addiction treatment. We are very far from hitting that goal. And so that should be the main driver of all of our policies, is how well are we delivering rapid access to all Californians. Next slide. This is where we are nationally. This is from the National Survey on Drug Use and Health. And what you see is that 95% of people who have substance use disorders within the past year did not receive substance use disorder treatment. And what people will tell you is that that 95% does not want treatment. And I can tell you from my experience that is simply not true. We are not offering treatment. We have put drug treatment behind lock and key and made it really difficult to access. So the very people who are experiencing the social chaos in their lives, we have made it excessively hard to access evidence-based treatment. Next slide. The radical and obvious solution that we have taken in our emergency departments is to universally offer treatment on demand. So currently someone walks into the emergency department, has a substance use disorder, and we start treatment on demand. This is both radical but extremely obvious that all people should have access to addiction treatment. So this has been our program. We are primarily using buprenorphine through the emergency departments, functionally because it is easier. Next slide. As my colleague mentioned, buprenorphine is a partial agonist. Because it is a partial agonist, it can be prescribed. So I can write a prescription for buprenorphine, and that individual can go to a pharmacy and pick it up, and then attend a clinic appointment in 2 weeks' time. Can be prescribed currently by any physician with a DEA license. Previously, it was so difficult to access, only special physicians could prescribe it in a limited number. We have a long history of providing very difficult to access, highly stigmatized care, and we are just starting to dig out of it. And we need to rapidly ramp up our ability to provide treatment to people who need it. So buprenorphine treats cravings and withdrawals. It is a partial agonist. It is not a full opioid, which allows us those flexibilities to prescribe it and then refer someone to any outpatient clinic. They do not need to be connected to a specific opioid treatment program, which is a lot more geographic flexibility across the state. Next slide. I want to reiterate, these medications are highly effective. They are not new. These are medications that we've had for a long time. We have decades of studying these medications. Buprenorphine, this is something we talk about in medicine, is how many patients do I need to treat to have an impact? To have an impact by giving aspirin, you all have heard of this, for a heart attack, I need to treat 42 people to have an impact. The entire EMS system that we have developed, which is designed to address cardiac arrests and provide defibrillation, they need to treat 2.5 people to have an effect. I only need to treat 2 people with buprenorphine to get someone into treatment. These are highly effective medications that we have studied for a long time. Next slide. This is our California Bridge program. What I want to highlight for you from this data that is statewide, looking at the number of people that we have engaged in treatment, is of the folks that we have identified, and just keep in mind, this is a tiny fraction of the people we could be reaching. 176,000 people we identified with opioid use disorder. 76,000 were started on treatment in that visit. So remember the myth of 95% of the people who don't want treatment? Here I can tell you about 40% of the people that we encountered in the emergency department accepted treatment on that visit. These are the traditionally hardest to reach individuals: people with co-occurring mental illness, people with unstable housing, people who are currently disconnected from traditional sources of care. This is the population that most people will have you believe is treatment resistant, and we can see that it is not true. Next slide. What we have learned is that low barrier, easy to access treatment drives increased demand for treatment. The reason we do not have more people in treatment is because we have not asked if they want it. Next slide. Currently, our outpatient treatment, we have focused on the specialty drug Medi-Cal system, which is primarily our methadone clinics, but we need to incorporate all areas of care. We need to incorporate primary care, emergency departments, federally qualified healthcare centers. We need an all-hands-on-deck approach so that all places where an individual can access care is able to provide them that rapid access to treatment. So I'm going to leave you with the final piece where we should all be, which is all people deserve rapid access to treatment. We're very far from hitting that goal, but overdose, particularly opioid use disorder, is a highly treatable disease process. This is a solvable problem, and we actually know how to solve it. We just